We've got a bleeder here. This kid took a bad tumble on his bike and has a wide cut. Let's get him into Bay 9 right away.
Okay, what do we have here?
Fell off his bike in front of my house. He has a pretty big cut.
Yes, let's put a bandage on there to control the bleeding.
It's on.
All right, we're done here. Great work, everyone. Another problem solved.
Wait, what? You controlled the bleeding, but it's a big cut. What about sutures? What about cleaning the wound to avoid infection? Just because you've temporarily managed the problem doesn't mean it's solved.
I need to complete the patient assessment. He is not bleeding anymore, so that intervention worked. We've addressed the bleeding, so I'll write no needs.
This person still has needs. You've addressed the bleeding, sure, but won't more work need to be done to help resolve this problem?
I see where she's going with this. As we consider this patient, we need to remember it's about the person and not the person in service. And that's the TCOM Heuristic of the month.
If you're trying to help someone change their lives, that doesn't mean you've become a permanent part of their lives. You get involved, you help, and then you help them transition out of care. That's a simple but critical concept of transformation. Many of the interventions we use with people are supportive, but not all of them lead directly to personal change. It's important to reflect that reality when we tell people stories.
Dr. Valentino to the OR, please. Dr. Valentino to the OR.
We've got a feeler here. History of depression and having some struggles right now.
Let's get her some therapy, stat.
Wait, is this an ER or a therapy setting?
Okay, doctor, therapy is in place and the patient has had a good couple of weeks. I'm going to mark this problem as resolved.
No, we just talked about this. Any service like therapy can be covering up a need, but the need might not yet be resolved. We sometimes call this masking. Therapy might be helping this patient on the road towards personal change, but 2 weeks probably isn't enough for that change to take hold. Hopefully, this therapy is managing the current needs and working towards resolving them down the road, but if we're continuing to work on the need in therapy, we should still reflect that in our assessment.
Dr. Valentino to the OR, please. Dr. Valentino to the OR.
We've got a learner here. Kid needs a ride to school.
Okay, this is not really the role of an emergency room.
It's okay, I think I've got this. Sometimes the caseworker shows up at a young person's house in the morning and makes sure they're ready and gets them to school. The youth might get better grades and have improved academic performance as a result.
So I shouldn't put school attendance on the assessment?
You should. They still have the school attendance need. It's just being managed at the moment by the caseworker. It's not until the youth no longer needs the support that you have effectively eliminated the school attendance need.
You're finally starting to get it.
Dr. Valentino
Really?
to the
We're still
OR,
doing
please.
this?
Dr. Valentino to the OR.
We've got a sweet tooth here. Patient has diabetes.
If you have to take medication to control your diabetes, those meds don't eliminate the diabetes. Chances are good that you'll be on that medication most of your life. As long as you need support for your insulin management protocol, that's an actionable medical need.
Yes, maybe once you're skilled and consistently managing it yourself, it becomes a need to keep an eye on. But it's likely never a need that goes away entirely.
Okay, but why do we approach it this way? Isn't it easier to just represent the needs that we can clearly see?
There are really important reasons for this approach. First, it allows us to document ongoing needs and distinguish them from things that have changed in a person's life. A bandage is a clue that a need still exists. The wound needs to heal and might take a while to do so. The bandage helps the person return to the community and continue their life. We want to acknowledge that the need is still there and still requires work.
Like monitoring for infection, changing the bandage, that kind of thing.
When we use tools for decision support with people in a structured setting like a residential facility, we should acknowledge that there's probably still an underlying need, even if it's not showing up.
In that case, the facility itself might be the clue that a need still does exist.
The person might be doing quite well in that artificial setting, but we don't know yet if their needs have resolved, and probably can't know until we've helped a person transition safely back into their community setting.
It allows us to describe person-centered outcomes across systems of care. You might strive in your emergency room to stabilize your patients and then move them on to other caring professionals. That's an important step, but it isn't the true goal of the medical profession.
No, our goal is to help people heal and live healthy, productive lives.
So if we only measure outcomes based on the episode of care, then we don't really serve people in a person-centered way.
Transitions from an emergency department or a residential treatment setting might look nice on a spreadsheet, but our real purpose is to help people make transformational change in their lives.
Thus, we need an assessment that thinks about the person, not the person in care.